Mix up the eight, but I'm Romano. I'm the Director of Government Relations for PSI. Real quick, it's a national nonprofit patient assistance organization. We help people who have very expensive chronic illnesses and conditions access treatments and therapies. We raise private donations, help subsidize health insurance premiums, pharmacy treatment co-payments, and Medicare Part D and Part B expenses. Our role today is going to talk about what is insurance and kind of do an Insurance 101. So the first slide, what is insurance? Obviously from all of us, there's many different types of insurance, but insurance really is the transfer of risk from one entity to another in exchange for payment. It's a type of risk management strategy that you're basically playing the odds. Against a kind of unexpected loss. Several different types of insurance. You have car insurance, which everybody has to have. You're going to drive a vehicle. Liability insurance. Accidental insurance in case you have an accidental death. There's life insurance, which people with expensive chronic conditions have a hard time obtaining. There's long-term care insurance. Obviously, today we're going to be focused on health insurance. And so I'll just move on to the next slide. So health insurance is one of these types of ways we manage risk and spread the risk really over lots of people. Obviously health insurance is a way of obtaining coverage in the United States for where you can get your health care. And there's many different types of health insurance. There's private commercial insurance. There's Medicare, which is a form of public coverage. There's Medicaid, which is public coverage for the poor. So it protects individuals from paying the full costs. There's nothing like if you were uninsured and going into a hospital and then handing you the bill, which has like $100,000 on it. And obviously, there's a sticker shock. So having health insurance prevents you from having that problem. Individuals, in theory, can choose a plan, and that plan has defined benefits. Now, many of us obtain our health coverage through an employer who gives us a choice of hopefully two plans. Sometimes it's here's our plan, take it or leave it. But in theory, you get to choose your plan, and then that plan has a section of defined benefits, of which then your coverage applies. And so then you pay a monthly premium on a defined basis. Again, is it monthly, quarterly, annually? And your end of the bargain is paying the premium on time, and their end of the bargain is helping you with your defined benefits of what they're going to pay. So your insurance agrees to pay the portion of your covered medical benefits, and you agree to pay where they don't, basically in different forms of cost sharing. Can I have the next slide, please? So, health insurance is different than other types of insurance because if you are sick, you're going to need it. There's kind of competing interests and complications with that. For individuals, you want access to as affordable coverage as possible, quality care. So you want the best care you get, and you want your child. I have 3 daughters. I have a 6-year-old, and I have 14-month-old twins. And I want them to get the best health care. The little Ashley was in the NICU for several days. I wanted to make sure that she had the best care that she could get. So obviously, and if possible, I want to have to pay a lot for that care. Payer is a for-profit enterprise that controls costs. They have a bond. Even the Blue Cross Blue Shields, which at times were nonprofits, just because it was a nonprofit doesn't mean they weren't needed reserves, and they didn't have shareholders, and them are for-profit now. And they're expected as any business to turn profit and to reduce costs in every way. So that's what's important for the payers. And then, of course, your employer wants to be able to offer the best benefits to obtain the best and brightest talent for his organization, or at least in theory, that's what you're hoping for. And obviously they want to offer, but they want to keep their costs low. So, and you don't want to pass a lot of that premium on to you. Now, most lawyers will pay a part of your premium, and you'll pay another part, depending on what your insurer is like. So, it's a complicated, I would say, seesaw of trying to find the equilibrium of great coverage, great access, and then price. And then you have different multiple actors in this arena. And so it makes for a lot of pushing and pulling, and really trying to make sure. But from my perspective, it's making sure the patient has access to the quality care and is not stopped by price. The next slide, please. Several different types of coverage. Now, I talked about it earlier. You have private coverage, and that's in a commercial insurance market where you can actually, like, I don't know how you say market. I either think of like the grocery store, or I think of something even more exotic, like in my daughter loves Aladdin, and we're in Aqaba, and we can get this very elaborate market. So the marketplace where you can obtain private coverage. There's public insurance, which is provided to you by the government, and it's governmental insurance, such as Medicare, Medicaid, Medicare for the military. So Medicare Part D is a hybrid of private insurance companies who must give you coverage through that market. So this is the different types of insurance. You get your private coverage and your government coverage. Many people want to expand government coverage to a single-payer system. Others, on the other side of the spectrum, want insurance to cover everything. So it is really a dichotomy here in the United States. But public insurance is considered insurance. Please. So actually, how is America covered? Because we have all this, there's the uninsured, there's the underinsured, where do we get most of our coverage? Now, Kaiser Family Foundation did a study, do it every year, a survey. It's usually halfway, July 1st to June 30th kind of. So for 2012, 2013, which is our latest survey, it says that 48% of Americans are offered insurance through their employer. The employer-sponsored insurance is the main place where Americans are obtaining their coverage, whether it's self-insured plan or a plan that has a third-party administrator, or some other type of hybrid of that plan. Most of Americans obtain their coverage through the employer. Now that has actually declined a little over the years, but still already get that. 4% of Americans obtain their insurance through other markets. That's meaning basically in the individual market. So instead of a group risk pool, which reduces costs for the individual and the employer, people go out and obtain their coverage that way. A lot of people did that through risk pools, high-risk insurance pools in the past. Some people have just opted. There was HIPAA policies in the past that helped you guarantee coverage. There was COBRA, which we'll talk about later, that again, you could elect to keep. So these were individual plans in the individual market. There's open enrollment plans that basically where 5% of Americans obtain the coverage. Most of them were prohibitively expensive. You were probably had to pay 100% of your premium. So 16% of Americans obtain their coverage through the Medicaid program. And we'll talk about Medicaid a little later, but that is a government insurance plan. 14% of Americans obtain their coverage through Medicare. Medicare is for the elderly over 65, or you qualify because you are disabled. So that's 14% of the American population. 1% through other public programs, it's S-CHIP, and other coverage, state Indian Health Service. And then 15% of Americans are uninsured. Now, the number will surely decrease by the time of the next survey because the Affordable Care Act had not kicked in at that point in this survey. Next slide, please. Here are some glossary of terms for you that everybody should learn when dealing with their health insurance. Now, I tell people is you really should read your policy. Now, with that, I really should cut down on red meat and run every day. Whether I do or not are two different things. So these are things you should know about your policy. First of all, what your medical benefit is or your major medical. And that's what the insurance coverage is associated with your serious illness, your hospitalization. That's like the meat of your benefit. That's not your prescription drugs. That's going to the doctor, getting your checkups, getting your colonoscopy, this kind of things. Plans have a set amount or a deductible flat of what that they pay, and for your major medical benefits. Usually, in the past, it's been an 80%, 20%, 80%. The plan usually pays 80%, and you're responsible for 20%. Then there's something called the pharmacy benefit. The pharmacy benefit basically is a standalone part of your policy, or it's part of your integrated into your coverage, for which really covers the actual drugs, treatments, and therapies. Usually there's a co-insurance or co-payment associated with that every time you get a prescription. There's something called a deductible. Usually after you pay your premium, you have to satisfy a deductible of some kind that help you. It's a good thought that you can get deductible for this. It's kind of a crazy method of payment, but you can get your deductible. Co-payment is the amount of the insured person must pocket so the insurer pays for a particular visitor. So you're going to have to pay part of it. Co-payment. It's usually a set amount, which again then the individual is responsible for. Can I have the next slide, please? So over there, I apologize. Is something wrong? Can I have the next slide, please? So co-insurance, which is a percentage of the total cost of treatment that the insurance company must pay. An example is 80% that the plan pays, and you have 20% of the cost. So it's not a set dollar amount like a co-payment. It's a co-insurance, which is a percentage. A lot of people have co-payment and co-insurance interchangeable. They're not synonymous. One's a fixed amount, and is a percentage of the cost. And you'd rather have a co-payment than co-insurance, trust me. What is a pre-existing condition? Well, that's anything like a medical history, a medical condition, anything that would have prevented you in the past from obtaining coverage. So I have asthma, that's a pre-existing condition. If you had cancer, a heart attack. So what is catastrophic coverage? It's a health plan that covers essential health benefits, has a huge deductible, so you have to satisfy a huge amount of money, and it provides a safety net in case you have an accident or illness. You probably will have to pay a lot more money in cost insurance and such. What is utilization management? That's that's a tool that insurance providers use so that you can find the appropriateness of your treatment. So you basically look at, evaluate the appropriateness of the treatment to make sure you can use it. It is a cost tool for insurance companies use. Have the next slide, please. So what's a prescription drug formulary? That is specifically what insurance plans have, the list of drugs on different tiers of what they'll actually cover. So if your drug isn't on the formulary, they're not going to pay for it. So when you do your homework, you see and call the insurance company at the start of your plan year and figure out when your treatments are covered. It's a specialty formulary specialty tier. Well, for more expensive treatments, insurance companies have been placing treatments on what is called the specialty tier or tier 4, and that allows them to charge a large co-insurance, a huge co-insurance. Sometimes, 20, 30, 40% co-insurance is a percentage of the treatment, not a co-payment, which is a select number. PSI has been very active limiting these tiers, these co-insurance tiers. What is a prior authorization? Well, individuals or doctors basically need permission from the insurance company before a pharmacy will fill a prescription. So you have to actually clear it, basically, with your insurance company before the pharmacy will dispense it. So the pharmacy needs to know the insurance company is going to pay, so then that's what the prior authorization. final thing here is step therapy. That is a practice of using the most cost-effective therapy first. Then it's basically fail first. They give you something that is the cheapest. You fail off of it, and then they let you have another, then you take another drug. PSI and other organizations, IDF, I know, has been very involved in stopping that. If you want to have the best brand name drug first, that's what the doctor wants you to have, then we've been leading campaigns to stop this fail first mentality that some insurance companies have. Got to know if they have a step therapy policy at your insurance provider. Next slide, please. Let's talk about some public health insurance. You have Medicare. Medicare is close to 50 years old next year, 2015. This is a Medicare insurance program for people who are 65 or older. So it was to help reduce medical coverage to senior citizens. They were usually the poorest Americans prior to the Social Security Act and then the Medicare, which was basically an amendment to the Social Security Act. And this is to provide old age coverage to seniors. They've since actually expanded it to include disabled, so people who are labeled disabled. So we're 50 years old. Originally, Presidents Teddy Roosevelt, Woodrow Wilson, and Franklin Roosevelt had looked into a form of Medicare at one point, and then it was President Truman tried it, and then it was Johnson who actually got it passed. And it's actually that there was also in that compromise to build Medicare, actually passed Medicaid, which is a social insurance program for the poor in this country. Is a state and federal partnership, which basically means the state puts in a amount of money and is matched by federal funds. Humorously, I'm going to tell you a little bit of history here. States, Wilbur was the legendary chairman of the Ways and Means Committee, who created the Medicaid programs. And to get Medicare, he had Medicaid, and to get Medicaid, he made sure all southern states got you $3 from the state put up. So the federal government had to pay $3 to every $1, whereas northern states got a lot less generous match. New York's 1-to-1, Pennsylvania's 1-to-1. Every other state's put in, the state puts in $1. So humorously, he says that was the South's revenge for the Civil War. But that's how Medicaid came to be. You had S-CHIP, which was actually started by Senator Kennedy and Senator Hatch, which is a state and federal health insurance partnership to expand coverage for kids. So 29 states have S-CHIP programs to ensure coverage for kids. You have TRICARE, which is a health insurance benefit for military, retirees, dependents. So the TRICARE, TRICARE for life. You have a form of government coverage. And you have VA benefits. And personally, when the Part D program was being released from Medicare, I was at my in-laws' house, and I live in Virginia, and I drove all day, 8 hours for Thanksgiving. I get there, and this was opening for Part D, and I unloaded the car, and minutes after I sat down, my father-in-law dumped all this insurance stuff on me. For about another 3 hours, I went through, looked at the different flares, where Parkinson's was covered, what it wasn't. I came home and I said, Mom, here's the deal. Here's the different things. I think that this is the perfect for Dad. He needs this coverage. And she looked at me with a blank stare and goes, your father gets his drugs to the VA. Those 3 hours I'll never get back in my life. But nonetheless, VA offers certain forms of coverage too, health benefits for military retirees. Kind of the next, so there's also some pre-ACA health protections. We have basically COBRA, which is was sort of 1986. It was basically allow individuals to continue their coverage if they lost their job. Interestingly enough, so it runs continuation from about 18 to 36 months. You're responsible for 100% your premium, the administrative costs. You have 60 days basically to elect COBRA. We always have a picture of a snake and say, don't be afraid to pick up the COBRA. But you have 45 days to pay. So basically that's the deal. And then you are you got the 18 to about 36 months of coverage, and then you can go into a HIPAA plan. Have the next slide, please.
I want to for his presentation. We have along to our next presenter. If there are any questions for James or any presenter yet to speak, please send your question to Katie, the Global Genes host, and we'll get to the questions as soon as the presentation is over. I want to introduce our next speaker. White is the founder and president of Horizon Government Affairs. Please welcome Joel.
Thanks, Michael, and thanks for the webinar. I am going to talk less about how health insurance has evolved, say, from World War II forward, and focus more on the Affordable Care Act. If you go to the next slide. So I think if you haven't heard of the Affordable Care Act, just open up any newspaper in the country and you'll see a story on it. It was the most sweeping reform of health insurance and health care since Medicare was enacted in 1965. It definitely impacts every American in one way or another, expanding private and public coverage, as was discussed by the previous speaker. It's financed by tax increases and entitlement cuts, primarily in Medicare. Largely redistributes income and creates some winners and losers. So some people will see cost increases under the law. Some people will see significant savings as a result of the law, and we can get into some of those issues in a bit. I think the point is that it is highly contentious law, and we're still fighting over it. If you open that newspaper and read the story, you'll see a Republican saying one thing and a Democrat saying another thing. And yesterday, the House of Representatives passed a bill that would clarify how the law applies to international programs. So Congress is still passing bills, introducing bills, trying to make tweaks to this law, and of course still discussing whether the law should be repealed or not. So it continues to be a highly contentious and political issue. You go to the next slide. Get into is more of a what is the ACA and what does it mean for me? So we're going to talk a little bit about the mandates in the law, what's required of me, what do I buy and when do I buy it, where do I get my coverage, and how will it impact me at a personal level. And that category is going to be a little bit more difficult to get into, but we'll try and address it in an appropriate way. So you go to the next slide. So what's required of me? These are mandates, and a lot of people have heard of this because we just passed the open enrollment deadline for individuals. But if you're an individual, basically the law says you've got coverage or you have to pay a tax. And that tax is the greater of a dollar amount or a percentage of your household income. So this year, if you don't buy coverage, you have to pay $95 or 1% of your household income, whichever is more. It increases over time in 2016 to $695 or 2.5% of your household income indexed in perpetuity into the future. If you're an employer, the law also says there's a few things that are required of you. You've got to provide affordable coverage to your employees or pay a tax. And if you have at least 50 full-time employees or more, you pay a penalty if one of your employees receives a tax credit. And it varies, but basically you're paying either $2,000 or $3,000 per employee based on your individual employer situation. But the concept is you're either providing affordable coverage that meets minimum standards to your employees or you're paying a penalty. And the theory there is that if you're not providing the coverage, the individuals have some place to go in the marketplace. You can go to the next slide. So let's get back to the individual. So this is what's required of an individual. I said you either buy new coverage or you can continue your acceptable existing coverage, Or you can apply for an exemption that they wouldn't apply to you. You can pay a tax. So there are primary options there. And if you choose the coverage route, you have to have minimum essential coverage. And that's a fancy term for saying you have something on a list of acceptable coverage sources. So an employer-sponsored plan, a government-sponsored program like Medicare or Medicaid, a plan in the individual marketplace. This is either through a new exchange or off an exchange. Or some other coverage like what was previously mentioned, the state high-risk pools, or acceptable coverage as approved by the Federal Department of Health and Human Services. So what it doesn't mean is limited benefit plans or accepted benefits such as dental only or mini-med, like plans that only cover a small option of benefits, or a short-term policy like a bridge policy lasting only 3 months. Those are not acceptable sources of coverage. Or to apply for an exemption, as I mentioned. And this is, it's been a little bit contentious because the rules are still changing and unfolding, but if the coverage is unaffordable, that is, if it's more than a percentage of your income, 9.5% of your income, if you're low income and you don't file taxes, you can get an exemption. If you're an Indian tribe member, you're getting your coverage through the Indian Health Service, so you get an exemption. You still have to apply for it. If you've got a coverage gap of less than 3 months, if there's some religious objection, like if you're Amish or Mennonite or one of those religious entities, you can apply for a religious objection. If you are an unlawful entrant, that is to say, you're not legally present in the United States, if you're incarcerated in prison, or there's a catch-all category called you apply for a hardship exemption. And so if you remember the rollout of the Affordable Care Act on healthcare.gov, there was problems initially in October, November, December. They cleared up at the beginning of the year. People had problems signing up. And so if you ran into problems subsequent to that, they created this kind of catch-all category where you tried to do it, but it was too hard, or you ran into some hardships since then, you can receive an exemption. So, and keep in mind those 4 categories: apply new, keep your existing, get an exemption, or pay a tax. So, when do I have to do this stuff? Well, the open enrollment period, as I mentioned, ended March 31st this year. For 2015, the coverage open enrollment will begin November 15th and then end on February 15th, 2015. So I have a couple months there to shop for plans and actually enroll in them. You can also have a special enrollment period. This is a time outside of the open enrollment period in which you have a right to sign up for coverage, and it's generally 60 days following a life event. And what are those life events? Well, if you get married, you've suddenly gone from individual coverage to family coverage. If you're having a baby or you're adopting a child, or maybe you're placing a child up for adoption, you've changed the size and scope of your family. You're moving. You're going to a different state. So if you've been purchasing coverage on the Connecticut Exchange and you're moving to Kentucky, you're going to have to sign up for new coverage. So that is a special enrollment period. If your income or your household income status changes such that it affects your eligibility for premium subsidies, you can have a special enrollment period. And then if you gain status as an Indian tribe member, you would then switch over to the Health Service, or you could change and sign up for a plan under a special enrollment period. If you're denied or turned down for a special enrollment period, you can appeal the decision. Each state has separate rules that apply for appeals are made. And if you go to healthcare.gov and do a search for appeal, that'll bring up some helpful information about where you can go in your state in order to file an appeal. And it's a bit of a process. You've got to file a letter and explain circumstances. but again, go to healthcare.gov, search for appeals, and you can get that information. And then finally, an overlooked thing, I think, is that you can apply for Medicaid and CHIP coverage at any time. So if you've missed the open enrollment period and you think you might qualify for Medicaid or CHIP, it's worth checking out the enrollment process in your state for one or both of those programs. Go to the next slide. So that's a when. What? What do I? Law, like I said, makes sweeping changes to the health coverage available, and most plans have to meet these different changes in the PRE-ACA. The first is essential health benefits, and so you've got to cover 10 categories of essential health benefits. These include prescription drugs, hospitalizations, physician office visits, things of that nature. What the plan covers is known as actuarial value, and it's basically the percentage that's covered by the plan, and conversely, the amount that's picked up by the individual or the family. And that's determined on metal levels. The lowest is bronze, the highest is platinum. So think of bronze a little less expensive. Think of platinum as a little more expensive, but also more robust. Out-of-pocket limits, there is an annual cap on the amount that you pay out of pocket. On 2014, you see the amounts there. The important thing to know here is that if you're incurring costs out of network, spending that you're paying for the out-of-network service, say for a specialist, won't count against that annual maximum cap. Spend $100 on a specialist out-of-network, it will count against $6,350 maximum out-of-pocket cap for that year. There are plans used to impose annual and lifetime limits on benefits. Both of those were repealed by the law. Yearly, the annual limit on essential health benefits took effect this year. And then the pre-existing conditions used to be that some people could be excluded for pre-existing conditions for, say, a rare condition or cardiac issue or diabetes. In 2010, those were prohibited for children under 19, and this year they're prohibited for adults. Slide. So I think important thing to know is that health plans have to issue you coverage, and they have to allow you to renew your coverage regardless of your health status. And young adults can remain on their parents' plan until age 26. Health benefits, those are just listed out there as a resource. Again, it covers most major medical hospitalizations, ER services, physicians, and prescription drugs. There are restrictions on how plans are priced or the monthly premium that you pay. So plans can no longer rate or set their premiums based on health status. So if you had cancer before, typically your premium would be a lot higher than if you were, say, a 25-year-old marathon runner who didn't smoke. Law, though, premiums are still allowed to vary, and they vary by age, tobacco use, the policy type, and where you live geographically. And then finally, if you're enrolled in a wellness program, it is allowed to provide a premium discount up to 50%. Right now, it's authorized up to 30%. Go to the next slide. So where do I get my coverage? The way I like to think about this, and I think is helpful, is you've ever been in a mall. Of course, we all have. In the mall, you have different stores of varying degrees of expense. So think like Nordstrom and the Gap and maybe Old Navy. And so you go into the mall, that's kind of your exchange, and you can pick from the stores in there, and you know the products in those stores. Think of the stores as insurance carriers. And products in the stores, think of those as the various levels of coverage, so bronze, silver, gold, platinum. Individual side, you can an exchange. States have set up their own, and Healthcare Gov is the dominant provider. And you can see there that 8 million people have already selected coverage. Through the exchanges, many will be subsidized. There's a similar thing for businesses, small businesses, called the SHOP Exchange. They'll become effective in 2015. You can go to the next slide. You just see the map of how states have organized their exchanges. Again, the dominant provider in the blue there, the light blue, is the health.gov. Go to the next slide. This is what people have available by state. And so the green is where you have like a lot of choice of insurers. And the deep blue is where you have limited choices. But, you know, as you see, there's at least a choice of one in all 50 states and territories. Some states much more robustly competitive. You can go to the next slide. And then finally, in terms of coverage types, many states have chosen to expand their Medicaid program. Basically, the law allows people, adults with incomes less than 138% of poverty, which is about $33,000 for a family of four this year, to qualify for Medicaid. All states have expanded their program. The Supreme Court made that optional when they ruled in 2012 on the law. But states are contemplating, they are treating Medicaid under the Affordable Care Act. And if yes, the orange states are the ones who are not expanding their programs. The green states are the ones that expanded their program. You can go to the next slide. So how will the law impact what I pay? And here we have a number of differing pressures. First, there are premium subsidies and cost-sharing subsidies and pooling arrangements that will lower costs. On the other side, you have rating rules and the actuarial value and essential health benefit mandates that will increase costs. And how this works out is going to create win-losers. Some people will see their premiums go down and have a significantly more affordable options. Others will see their costs go up. And it really does depend on your individual situation. You can go to the next slide. So this is a slide that basically shows how the premium subsidies operate. And basically, if you have less than 400% of the federal poverty level in income, your premiums, what you pay, is held to a percentage of your income. So at 4% of poverty, you won't pay more than 9.5% of your income in premiums, all the way down to 133% where you'll pay 2%. And you can see the next chart over is what is the level? What does that mean based on household size? So at 400% of the poverty level, family of four, that's $95,000 a year. So just slightly below that, you would not pay more than 9.5% of your income on premiums. In addition, a lot of people don't know there are cost-sharing subsidy reductions, and they're kind of set up the same way. They basically limit your exposure to cost sharing based on income. So you can see there the reduction in your out-of-pocket limit, that annual limit, and what it does to the actuarial value of the plan you select. So for the person at 100% poverty, you can pay more than 6% of the cost of the benefits you receive as a result of the cost-sharing subsidies. Next slide. So actual experience, this shows the premium variation amongst bronze, silver, and gold plans on a monthly basis. So at the level, or the silver level, which is the most popular level, lowest monthly premium, you can see there 50-year-old in the federal exchange, $335, and then up at the top, $619 for Alaska. The next slide. So it's important to go through. Plans did come into the marketplace with competitive premiums in 2014. They really wanted to sell at a price point that was competitive to attract favorable risk. but law restricts plan flexibility in a number of areas: rating rules, the actuarial value, essential health benefits, and so. And so for the plans to be able to make their business viable, there are strategies they can take. They can charge higher premiums, which they chose not to do as a market strategy in 2014. They can impose higher cost sharing, they can restrict coverage, or they can seek out better risk pools. And so what we're seeing in the marketplace in 2014 is some changes we hadn't seen in the typical plans in the individual or employer markets previously. So network design, we're seeing narrower networks based on higher quality or lower costs or a combination of the two. We're very high cost sharing requirements, high deductibles, separate drug deductibles, and formulary tiers and formulary design. So we're continuing to monitor the market and see what the 2015 brings. But our understanding is a lot of plans are looking at double-digit premium increases and perhaps continuing some of the design elements like network design and sharing requirements that we're seeing in this year. You can go next slide. Employers, I think, are moving beyond a wait-and-see mode. They are analyzing the cost impact and making strategy decisions about their plan for 2015. There's a lot of cost management techniques, including shifting more premium costs onto individuals, increasing deductibles to mirror what we see on the exchanges, dealing with out-of-pocket limits, and increasing cost-sharing requirements. Some are also reducing benefits in order to avoid what's known as the high-cost plan tax, or the Cadillac tax, which takes effect in 2018. Then some employers we know, particularly small employers like franchises and retailers, are limiting employee hours and reducing the number of full-time employees in order to get below the 50 employee limit on the employer mandate. The next slide. That's it for me. I took a lot of time, so I appreciate it. Thank you.
And we're going to go to final speaker, the only person who is speaking once but being introduced twice. Larry Lott from the Immune Deficiency Foundation is responsible for all public policy matters. And again, welcome, Larry.
Thank you very much. And I guess now it's really getting down to the nitty-gritty of what do you really need to know when you are actually picking a healthcare plan. And is good for not only the healthcare marketplace exchanges from the Affordable Care Act, but also in picking any insurance company if you have choices through an employer. However, these are some of the things that you need to know when picking a health plan. Next slide. Immune Deficiency Foundation is a national patient organization, and our patients are born with a malfunctioning or non-existent immune system and are thus susceptible to every disease and every virus and every bacteria that comes along. And so that's who the Immune Deficiency is advocates on their behalf. Next slide. Two things to really consider when you're picking a plan is what the benefit design will be, which will take care of not only your general health care needs, but in the case for people with rare diseases, but also how your treatments may be covered within any particular benefit is a critical piece of information that you need. The second prime thing is really what you've heard previously, dealing with the cost, the premiums, the deductible, the co-payments, and the insurance, what you're expected to pay out of your pocket in the future. So those two things together are really the prime considerations. Next slide. So, pick plan does a plan cover? Are my physicians in the network? These are all questions that you really need to delve into deeply and find out. Check out whether your physicians are in the networks. Find what exactly the plan covers, not only for your general health needs and your family's general health needs, but also for your specific treatments if you have a rare disease. What are your annual limits? What are your network benefits? Is everything going to be covered in network for your treatments, or do you have to go out of network? So these are all kinds of issues and questions that really need to be answered if you were to, when you're picking the right kind of insurance program for you. Next slide. We heard an explanation of what the major medical and what the pharmacy benefit are. And in your specific rare disease treatment, is that based or is that not drug-based? And for example, in our primary immune deficiency diseases, our patients are usually infused with an immunoglobulin, a blood plasma product. Most of the time that's covered under a major medical drug benefit, not in the pharmacy drug benefit, which is your other kinds of drugs that would be in the pharmacy benefit. And it's important to know where your drugs come from, whether it's the major medical side or whether it's the pharmacy benefit side. And I'll get into that in a very few minutes. Do you need to see a referral to see a specialist? Is pre-authorization, we talked about earlier, necessary? If your treatment involves drugs, will you have to do step therapy? Do you have to take drug A before you can take drug B, even though you're a doctor and you think that drug B would be the best for you, but the insurance company says you have to take drug A and fail that before you get to drug B? Next slide. So, getting answers to all these questions is really not easy. This is hard work. And you need to recognize that up front and be able to go into that with that understanding that this is not a 5-minute job. The relatively easy part, and I say it's just relatively easy because it still could be difficult, is find what your summary of your benefits generally are. Is generally covered with a summary plan document that is offered by insurance companies. Also is obtaining a drug formulary list is also really very common. For the pharmacy benefit, not at all when you talk about trying to get medical benefit, the drugs that are on the medical benefit formulary. So you need to remember those distinctions. The relatively easy thing is to get your provider network directory. Usually they are published online and or given to you as a booklet by your employer or by the exchange, whatever it may be. As I mentioned before, the medical benefit formulary is really hard to find, and you will have to go directly to the insurance company, which is really a pain, but absolutely, it's necessary that you do that. Next slide, please. Contacting your insurer is, as I said, it's a pain in the neck. First, go to the insurer's website and look for the coverage options that they have or listing of plans. Look for a case manager help that they may be able to help answer questions. There's always a contact us kind of on the website to try to get answers. Most plans have a telephone line, a customer assisted telephone line, and ask for whoever can provide assistance in using a plan. So it is really important to go to the plans and ask questions directly and try to get answers. Now, part of an employer-sponsored plan, ask for help from the agent or the agency who's working with your employer for any specialized questions. In terms of help with ACA, exchange marketplace plans, then you might also try to find a navigator who can help you navigate the two plans. Next slide. Company, contact your human resources to help you get to the right person at the insurance company. You need to be persistent, whether you're talking to your HR department or whether you're talking to an insurance company. If a person can't help you, you need to go to the next level, and you're right to do that. And be polite, but be firm too. I suggest that when you are trying to find answers, that you write down your questions before you ever get on the phone. So you have exactly, what the questions to ask. And just remember, there is no such thing as a stupid question, so don't be embarrassed to ask for anything. There's one better than you to be an advocate for yourself or your family. No one else, ever. You are the best. Next, please. You've heard about the components of costs, and just wanted to space just a little bit. The importance is to figure out what your out-of-pocket costs will be in the future. The cost of having the plan, the deductible one might have to pay, any co-payments, which are flat dollar amounts for services and drugs, and as well as co-insurance, which is what was described earlier as can be very expensive, a percentage of the treatment or drug. But keeping track and anticipating and looking in advance of what you think your out-of-pocket costs might be is extremely important in picking a plan. Next slide. Another aspect is to make sure that your physicians and your hospitals, your healthcare institutions are in your network. It is really critical, especially if you need specialists. It's critical that they be in network, because if they're in network, you can rest assured that you are going to be paying a lot more money out of your pocket for out-of-network coverage or providers. And as was mentioned before, none of that will go to the cap on annual costs. So making sure that all of your physicians are in network are critical. And if they're not in network, you have a decision to make, and maybe you need to find one who is in network. Next slide. What about utilization management before was that it was a tool or technique is to control overuse of expensive treatments. So talked about prior authorization. Restrictive formularies is another piece that it should be looked at. Is if you have several drugs that are available for your rare disease treatment or any treatment, and they only say you can only use one brand and one brand only, that may cause a problem. In our community, for example, there are a number of different immunoglobulin drugs. We know that our patients they tolerate different IG drugs differently, and that we know if someone is forced to switch, we can expect 15 to 30% of our population will have adverse effect. So restrictive formularies and knowing that you have them may cause you to think twice about a particular plan. Next slide, please. Therapy about failing first to one drug before you move to the next treatment drug is another consideration you need to look at in consultation with your physician. Next slide. People are familiar with the premiums, deductibles, and the flat dollar amount co-payments. And as Jim Romano mentioned a little while ago, most people don't understand specialty tier co-insurance. And this is very critical because you have to pay for an expensive treatment, and you have to pay a co-insurance percentage that is 20, 30, 40, 50%. It prices you out of your treatment, and that you won't even be able to get a treatment. So, a lot of people think that this is a form of sharing is economic discrimination because most people can't afford the cost, and thus will go care. It is important for you, before you buy something, to look at it and see where this comes down in terms of co-insurance for your particular treatments. Next slide. This is just an example of a co-insurance at 25% for somebody who has a $7,500 a month treatment, and so they're on the hook for $1,875 per month per treatment. It's extraordinarily high. Next, please. Shopping for a new plan, you really have to do your homework. There's a lot of homework, and one we suggest is that look at your past 12 months and include all your doctor visits, all your every contact that you've had with the healthcare system. Try to come down exactly what were your costs in figuring out what your healthcare expenses were for that year. You want to tally everything, including premiums, deductibles, copays, coinsurance. Then you need to look forward for the year coming up and estimate what will be your foreseeable cost for the coming year. And if you are in the ACA marketplace, you should estimate what your income would be and what the possible tax subsidy you may qualify for to offset premium costs. And there are now some tools in the market online that will help you figure that out. Right? We talked about what you need to get: a summary plan description, drug formulary, provider network, information on the healthcare savings or spending accounts that your employer might offer, and understand and know what the glossary of insurance and medical terminology are. Slide. Rare disease, the information you have collected will probably not be enough to make a decision for you. You will most probably have to contact the insurance companies again to evaluate the medical policies with your treatment and ask questions about those policies and get that specific information for rare disease treatments especially. Next slide. It's a lot more complicated than it used to be, but it's important that you keep records of everything related to your healthcare costs. There are resources on the internet, and you can go there and seek those. The National Health Council has an out-of-pocket cost calculator. There's various types of tools that are out there. Then, Immunodeficiency Foundation, we have our health insurance toolkit, which may be helpful, even though it's customized for our particular patient group. There's a tremendous amount of information on that toolkit, and you can see the web site to go to as help you for buying insurance. So look out there. It's kind of tough, and thank you very much.
I want to thank all our speakers, James Romano, Joe White, and Larry Mott, and of course Global Genes for hosting this great webinar and very informative webinar. Unfortunately, even though we got our speakers in under the clock, we are running over time to get to the questions. We have collected questions. They'll be stored, sent to the three panelists, and all questions will be answered up to or on the second webinar. If you have not asked your question and want to, please send your question using the right-hand side, the Q&A window, to Katie, the Global Genes host. In closing, I want to just remind everybody of some of the things that were talked about today. If you want to enroll or check out the marketplace and have yet to do so, please visit healthcare.gov. If you're looking for help, not sure where to go, what to do, visit localhelp.healthcare.gov and use that as a guide. Remember that you will be receiving a survey. That survey will provide feedback for the presentation you just heard and will help craft Part 2 for next webinar, which will take place May 28th, 1 p.m. Eastern Time and 10 p.m. Pacific Time. And again, please register now for Part 2 of this webinar series, which will not only provide further discussion on your questions and concerns following Part 1, but also detailed points to consider when attempting to overcome obstacles to accessing your provider or treatment in both government and commercial health insurance plans. As I mentioned, Part 2 is scheduled for May 28th, 1 p.m. Eastern Time, 10 a.m. Pacific Time. I want to thank you all for attending. I hope you found this informative, and we will talk to you again in under a month. Thank you very much.